help
Hello, welcome to today's presentation on the anesthetic management of severe pre-eclampsia. If this is the first time you are watching this channel, I will encourage you to go back to our previous discussions where we looked at the causes, the symptoms, how to diagnose pre-eclampsia as well as severe pre-eclampsia, and also the management of pre-eclampsia and severe pre-eclampsia. In this section, we are going to look at solely the anesthetic management. And if you remember, we talked about the fact that the fetus was in severe fetal distress, and so decision to go in for cesarean section was made. And so the question was, what will be the appropriate anesthetic technique? Should we go in for general anesthesia, or must we do regional anesthesia to deliver this patient per cesarean section? Now, in my years of practice and also literature supports that both regional anesthesia as well as general anesthesia can be given to this patient to deliver the fetus. Now, if we pick the regional anesthesia to begin with, it is not contraindicated, especially after an eclamptic fit, if the mother or the woman has regained consciousness and treatment for seizures and blood pressure control has been commenced. As a matter of fact, we recommend that women with severe preeclampsia should be encouraged to have regional anesthesia for cesarean section. This is because general anesthesia for cesarean section is always a high risk procedure, which we shall talk about in few minutes. Now, why can we even go in for regional anesthesia? There are enormous benefits, such as a rapid, dense, and a predictable block, which will be suitable for surgery, and this will help us to avoid general anesthesia, which has a high risk of even increasing the blood pressure due to the pressure response of laryngoscopy, intubation, and even at the end of the day during extubation. So when we give regional anesthesia, it helps us a lot. We also have better analgesia, and our airway is protected. We don't even tamper with the airway, and we are going to have better control of our blood pressure. Having said this, it is also important to note that this regional anesthesia may also be contraindicated in certain circumstances. For example, if there is maternal refusal of regional anesthesia, then we must respect that. It is the patient's right to decide. We can only make recommendations for what we think is in the patient's best interest, but we shouldn't coerce the patient to accept what we think is right for the patient. So when the patient or when the woman refuses spinal anesthesia, we must respect that. In certain situations such as coagulopathy and also bleeding diathesis, not all of them, but in some of them, such as the hemophilias, the vitamin K deficiencies, in disseminated intravascular coagulopathy, as well as some liver disease, even including some malignancies such as leukemias, there is a high risk of epidural hematoma, which may also lead to spinal cord compression, and so it is contraindicated for you to give spinal anesthesia in these women. Also, when there is thrombocytopenia, that's when the platelet level is so low, we still stand the risk of having bleeding, which will cause epidural hematoma, and also still lead to spinal cord compression, and so we wouldn't want to do this. Yet if there is poorly controlled seizure, you wouldn't also want to go in for regional anesthesia, and if there is severe fetal distress, you may want to quickly go in to deliver the fetus and save the fetus. And so these may be absolute contraindications for regional anesthesia in this case. There are a lot of contraindications. Even when there is infection at the site of the spinal insertion, it may also be a contraindication, since we stand the risk of causing meningitis in these patients. Now, once we have decided to go in for regional anesthesia, then certain considerations must be made, such as prophylaxis for hypotension. Usually a fall in blood pressure, which is a decreased systolic blood pressure of at least 25% of the baseline, or a systolic blood pressure less than 100 millimeters per mercury, is the most common complication of most spinal anesthesia in obstetrics. And severe preeclampsia or the eclamptic patient may not be exempted. This hypotension usually may result from increased venous capacitance, and also pooling of a large portion of the blood volume in the lower extremities, and also in the splanchnic bed. And there is also a decreased systemic vascular resistance. All come together will lead to these hypotension that we see. Now, it is believed that due to the depleted intravascular volume in severe preeclampsia, they are vulnerable to the hypotensive effect of the rapid onset of spinal anesthesia. But recent studies have also shown that they are actually less prone to this hypotension than normal individuals. This is because it is also known that preeclamptic patients have higher levels of circulating catecholamines, which may protect them against a fall in the blood pressure as a result of a spinal induced sympathetic block. Having said this, I always advise that putting the two together, we should always be on the safer side. Try to put all our precautions together and make sure that when we find ourselves in this situation, we should be ready to combat this hypotension. And so, which measures can we put in place to solve some of these problems? We can use what do you call it, a reduced volume of preload. If possible, with colloid. We can use colloid in a reduced volume, to do this. And if there is absence of colloid, and also if there are concerns of allergic reaction from the colloid, then we can give Ringer's lactate or normal saline 15 to 20 ml per kilogram half an hour prior to the regional anesthesia. Now, an important thing that I want to stress over here is that we should make sure that we do not give excessive fluid, because if we give excessive fluid load, we may cause pulmonary edema. You understand? And if we also do not give enough fluid, that is, if we underfill this woman, we may also compromise fetal circulation and also renal function. So we need to be careful and put much measures when we are infusing these women for spinal anesthesia. Now, it is important to know that we can give ephedrine safely, but we must expect that the effect of ephedrine will be increased. Now, post-operatively, we can administer analgesia to this patient. We must, it is a requirement, but we have to avoid NSAIDs. And this is because these patients are prone to renal impairment and may have, impaired platelet count or even platelet function. So we have to avoid NSAIDs within this period. The proteinuria will usually resolve within 48 hours, and so after this time, we can safely commence the NSAIDs and make sure we nurse these patients in the ICU. Now, like I said before, cesarean section under general anesthesia in severe preeclampsia is a high risk procedure. Why do I say this? This is because there is an increased risk of difficult airway and also intubation, like we've seen before, or like I've explained before. There is going to be pulmonary laryngeal edema. You understand? And so the chances of you failing to intubate is very high. You see, and there is also marked pressure response at laryngoscopy, intubation, and also during extubation, and this may even result, in dangerous increases in the blood pressure. And so, putting all of these together, the woman even stand the risk of, getting intracranial hemorrhage. You see, this intracranial hemorrhage may be secondary to a poorly controlled severe hypertension, at the induction of the general anesthesia. And so we usually recommend that all patients who require general anesthesia for cesarean section, we must make sure their blood pressure and also convulsions are maximally controlled, ideally. And we must make sure we have other supporting staff, senior colleagues to be there to also help us in these situations. Now, in which circumstances may general anesthesia be indicated? All the conditions which or all the contraindications to regional anesthesia are indications of general anesthesia, and so I wouldn't waste time on it to explain it. So it is indicated for general anesthesia when there is maternal refusal, coagulopathy, thrombocytopenia. Also when the seizure is not well controlled, and also when there is fetal distress. Now, what considerations must we make when we are choosing general anesthesia for this patient? Of course, we must assess the airway, and like we've seen or said earlier on, there will be obvious edema, and because of this, we must select a smaller size endotracheal tube, and we must also expect hypertensive response to laryngoscopy, and we must also expect prolonged effect of non-depolarizing muscle relaxant, and this is usually due to the use of magnesium sulfate in the management of the eclampsia, or even as a prophylaxis to eclampsia. And we must also ensure adequate analgesia before we extubate these patients. Postoperatively, analgesia may be required, but as I have already explained, we must make sure that we avoid NSAIDs. Now, in our case presentation, remember we took some blood samples to the lab. The results are in, and now the platelet count is 55,000, and the patient gives no history of stridor, voice changes, as well as hoarseness. And so quickly we set up an arterial line. Prior to induction. The patient is pre-oxygenated and in the left tilted position. In a rapid sequence induction with tiopentin 450 mg as well as succinylcholine 100 mg is given, and the patient is intubated with a size 7 endotracheal tube. At which point it was realized that the blood pressure has increased to 140 millimeters per mercury. We maintain anesthesia with isoflurane in nitrous oxide and also oxygen, and this woman is paralyzed with atracurium 40 milligram. Now, after the delivery of the baby, the woman is given 10 milligram of morphine and also antibiotics as prophylaxis is commenced. Now, at the end of the cesarean section, the woman is slow to wake up. So, how can we obtain the pressure response to laryngoscopy and also intubation? and what might be the cause of her slow wake up. So basically, we can obtain the pressure response to laryngoscopy and intubation by giving a short-acting opioid as bolus. Example, we can give our fentanyl 10 to 20 microgram per kilogram, or even remifentanil 1 microgram per kilogram to this patient before we intubate. And also we can give a bolus of labetalol 10 to 20 milligram IV to also counteract the pressure response to laryngoscopy. Then we can also give magnesium 40 milligram per kilogram IV, and also lidocaine 1.5 milligram per kilogram 3 to 5 minutes before induction is commenced. Now, some of the reasons why this patient is slow to wake may be because of effects of excess anesthetic agents, which is the first thing we must even think of, and also the effect of opioids. We've given this patient morphine together with all these anesthetic drugs that we've given. So the patient has no pain, and so nothing stimulates her to wake up. Now, it can also be as a result of inadequate reversal of the inadequate reversal of the neuromuscular blockade. Now, if you suspect that your reversal is inadequate, you can give another dose of neostigmine to the patient to reverse the neuromuscular blockade. Neostigmine is an anticholinergic, and this works by blocking the action of acetylcholinesterase, and therefore there is increase in the level of acetylcholine in the neuromuscular junction, and so the muscles are activated. So if you suspect that your reversal is not adequate, you can repeat neostigmine injection, but you must take note of the patient heart rate whilst you are giving it. If you think the heart rate is low, then you must add your atropine to it to counteract the effect of the neostigmine. Now, it's also important for you to note that magnesium, as we saw during our management, potentiates the effect of the non-depolarizing muscle relaxant, and so it may be a cause of the reason why the patient is slow to wake up. There may also be respiratory depression due to toxicity of magnesium. And if you remember, when we were talking about toxicity of magnesium, we said if you give magnesium sulfate of between 6 to 7 millimole per liter, then you can stand a chance of inducing respiratory distress in this patient. And also hypoglycemia may also cause delayed waking up of the woman, and so you must check the glucose level and manage it appropriately. Now, the intracranial hemorrhage that I talked about earlier on, due to the increased pressure response, should be quickly diagnosed, or can be diagnosed using CT scan in this case. Now, what will be some of the ongoing management that this patient must continue to receive? Before we look at the ongoing management, fortunately for us, over 15 minutes, this woman slowly wakes up and makes an uneventful recovery from general anesthesia, and so we all became so happy because our patient has come back. However, we must make sure we continue with the following management. We must ensure that effective postoperative analgesia is ensured. This is because it will reduce the stress response and also consequent hypertension, which is caused by poorly controlled pain. So we must give analgesia, but as I said earlier on, we must make sure we avoid NSAIDs until the proteinuria has resolved, usually after 48 hours. Now, we must also continue with our antihypertensive therapy. This should be continued even after delivery, as the blood pressure is recorded, or as dictated by the woman's blood pressure. Now, we must continue with this, and We must also know that although the blood pressure usually falls initially after the delivery, it may rise again around 24 hours postpartum. And so IV antihypertensives should be converted to oral therapy with further reductions made in a stepwise direction. We must also continue to closely monitor this woman, as there is a risk of further eclamptic seizure. And also magnesium therapy should be continued until 24 hours after delivery. It's very, very important, because there has been instances whereby these patients get eclamptic seizures postpartum. Then also we must monitor continuously the fluid intake and output, and we must pass a urinary catheter to see the amount of fluid that the patient is passing as urine. And also we must continue with a fluid intake of 85 mils per hour, and we must make sure we take away or we subtract the oral intake from the IV prescription. Fluid overload over here must still be avoided, and make sure we don't cause pulmonary edema in this patient. It is also important to note over here that most women with severe pre-eclampsia or eclampsia will need inpatient care for at least 4 to 5 days or even more days following delivery, and they must be taken care of in the intensive care unit. So this brings us to the end of our case scenario on pre-eclampsia, severe pre-eclampsia, as well as eclampsia. Thank you very much for your time.